Today we'll talk about nephrotic syndrome, how to characterize it, what the causes are, and how to organize it in your mind. Nephrotic syndrome has four cardinal features. The first is proteinuria of 3.5 grams per 24 hours. This in turn leads to hypoalbuminemia, as most of the protein lost is albumin. When albumin falls, this clinically presents as edema, which you can see either as ascites, peripheral edema, or pulmonary edema. And in an effort to replenish albumin, the liver starts to make more albumin, but it also makes more lipids, leading to hyperlipidemia. And category 4A, it also leads to the production of more clotting factors. In addition to losing clotting factors like protein C and protein S, the overproduction of clotting factors leads to hypercoagulable state. And patients with nephrotic syndrome often present with clots. So to summarize, proteinuria leading to hypoalbuminemia, leading to edema. The response of overproduction of albumin leads to overproduction of lipids as well as clotting factors presenting with hypercoagulable state. So a common problem for students and residents is how to categorize nephrotic syndrome. It should be categorized into two major groups, primary and secondary. Primary means what you would see on a kidney biopsy in any patient with nephrotic syndrome, and secondary refers to a cause leading to one of those histopathologic diagnoses. These include minimal change disease, focal segmental glomerulosclerosis, membranous nephropathy, and MPGN. So to reiterate, if a patient presents with nephrotic syndrome and a kidney biopsy is done, one of these four diagnoses will be the answer. The only clinical question now is it primary or is it secondary to something like diabetes, lupus, amyloidosis, multiple myeloma, HIV, or sickle cell disease. Now let's dig a little deeper into each individual cause. Minimal change disease is often associated with lymphoma and non-steroidal anti-inflammatory drugs. Its common presentation is explosive onset of edema over a few days to weeks and is exquisitely steroid responsive. Patients need to be screened for lymphoma if the diagnosis is made via chest x-ray, and a history of drug use must be evaluated, including non-steroidals. Focal segmental glomerulosclerosis presents commonly in African Americans, patients with HIV, and patients with a history of intravenous drug use. It's slowly gaining steam as the most common cause of nephrotic syndrome worldwide. Membranous nephropathy is a unique disease that presents indolently and in the 5th and 6th decade. Its profound loss of protein, often greater than 10 grams per day, leads to an increased prevalence of clots, including DVT, PE, and often tested renal vein thrombosis. Membranoproliferative glomerulonephritis is associated with hepatitis B and C, and MPGN can also be a cause of nephritic syndrome. In terms of the secondary causes, diabetic nephropathy is clearly the most common cause of nephrotic syndrome. Patients with diabetes cannot be biopsied all the time, so it's important to find other surrogate markers for disease. The number one marker includes retinopathy. If a patient has retinopathy and proteinuria, they almost certainly have diabetic nephropathy. If a diabetic does not have retinopathy and has proteinuria, other causes must be investigated. Lupus presents multiple ways, one of which is nephrotic syndrome, categorized as WHO Class 5, and an ANA is needed for the diagnosis. Amyloidosis and multiple myeloma are sister diseases and can be diagnosed with the use of SPEP and UPEP. HIV-associated nephropathy is a nephrotic syndrome similar to diabetes in presentation and can be evaluated by screening, just as sickle cell disease can be evaluated by screening. So in summary, nephrotic syndrome has its four cardinal features plus 4A, as I've described, and can be categorized into primary and secondary causes as outlined below. That's nephrotic syndrome.